Hi, I'm Greg Postma. I'm a professor of otolaryngology and vice chairman in the Department of Otolaryngology at the Medical College of Georgia at Augusta University. I'm the director of the Center for Voice, Airway, and Swallowing Disorders here in Augusta. Well, the number one thing we dilate are strictures. And the number one cause of strictures is gastroesophageal reflux. So the number one risk factor is reflux disease, which is endemic throughout North America and Western Europe, particularly in the United States. Our diet, lifestyle, and so forth we're very refluxogenic in general. Increasing body weight leads to increasing reflux, alcohol, tobacco. This leads lots of people to reflux. That leads to lots of esophageal strictures that need to be dilated. The other groups are the head and neck cancer population that develop a lot of strictures. And finally, there are groups of patients that are often missed that have very small proximal esophageal webs that are often missed on endoscopy and are also very hard to see on barium swallows and modified barium swallows. A number of us have large series of patients in which we could barely see a web on endoscopy, or on a modified barium swallow, a small web might be seen on a single frame of the radiologic examination, but then we put an endoscope into their esophagus under sedation or awake in the office or in the operating room and see a huge thick web. And we dilate this and boom, their symptoms are gone. And so we think that this is why about 20 to 25% of people that undergo an empiric esophageal dilation, that's a dilation just to see what happens essentially, but 20 to 25% of people get better. We suspect a lot of those people have these small proximal esophageal webs that we're just not seeing. And so we've found a lot of our people that will put balloons in there, dilate the cricopharyngeus area and the proximal esophagus, and even in people we don't see a web, they'll wake up and they'll come back and see us and say, oh my gosh, you can't believe how much better I'm eating. And so there's a lot of people I think that can benefit from this kind of technology. The question comes up about deciding to do dilations in the office versus doing dilations in the operating room. My primary reason for doing it in the office would be it's very easy for most patients, particularly if they've undergone a laryngectomy before. We can offer that service usually the same day if the patient so desires. If a patient can tolerate transnasal esophagoscopy, then the majority of them can tolerate a balloon dilation. And so we offer this in patients that don't feel the need to be sedated or undergo general anesthesia. Other patients are very open to it. So there's a lot of variety in there. In general, it's a combination of how I feel about a patient, the nature of the pathology, and then the patient's desires. There are a lot of benefits to doing procedures in general in the office versus the operating room. If one specifically looks at transnasal esophageal dilations, the benefits are it's less expensive, it's much faster than going to the operating room, the complication rate is lower, and it gets the patient back to work or home much faster than any other way. No matter how fast you're in the operating room, there's no way you can beat an efficient office setting to get someone back to work or back home. The response of different strictures is highly variable. A reflux-induced stricture that is dilated in a patient that's on anti-reflux therapy may never need to be dilated again. On the other side of the spectrum is a patient that's got a severe stricture of their hypopharynx or proximal esophagus after chemo and radiation therapy. Those individuals may undergo dilations a dozen times, trying to keep things open. We have some patients that come to us that have 100% blockage. Those people are clearly not initially dilated in the office. We take them to the operating room, but once we establish an esophageal lumen, we'll often keep that open with in-office dilations. Some of those are done every 5 to 6 weeks for a period of time until we can make certain the esophagus stays open. I'm certainly a fan of balloon dilation. Oh, having been raised in the bougie generation, if you will, as we all were for many years, I found balloons to be far less traumatic, both in the airway as well as the esophagus and the pharynx. When I do a balloon dilation, I think I get a lot less trauma in the region. I think I damage normal mucosa less using balloons than when I used to do bougies. And so for the most part, both in the pharynx, esophagus, and the airway, balloons have replaced bougies in the vast majority of my patients. Comparing and contrasting the operating room with the office is interesting. It seems that doing it in the operating room needs less people, but we're not including an anesthesiologist, an OR nurse, an OR tech, this type of thing. If an otolaryngologist already has an interest in dysphagia, there's not a lot of extra things he or she would need. If you're interested in dysphagia, you almost definitely have a channeled transnasal esophagoscope. That's certainly the most expensive piece of technology someone would need. You need something that you can look at the esophagus, look at a stricture, look at a web width, and then you have to be able to deliver a guide wire. And so a transnasal esophagoscope or potentially a bronchoscope is critical. After that, there's not a lot of other equipment that one needs outside of a balloon dilation system. We did a study on the economic differences some years ago, although we presented it but never did get it published. And it demonstrated that the cost of performing this in the office was less than a third of the cost in the operating room. And that's just looking at the direct costs. We found that the device is very much tailored to the length of our transnasal esophagoscope, and it's a perfect match for the systems we have in place right now.